So thank you everyone for joining for today's class on myeloproliferative neoplasm. The way I had actually written about this topic in our educational plan, our certificate course plan was what do we do when there is high hemoglobin, WBC, and high platelets, or one of these. So combination or one of these. Now we are all aware that anemia is the commonest clinical issue that all of us find in our patients, but increasingly as the overall socio-economic condition of low middle income countries improves, we see enough number of patients with high hemoglobin, high WBC, and high platelets as well. And it is always confusing to clinicians as to, hey, look, if the hemoglobin is increased, should I just ignore it? Should I test? Should I just ask my patient to donate some blood? Right? Many patients come to us, they say, last 3, 4 years, my hemoglobin has been high. And my doctor has been saying, don't worry, just give some blood. You have a lot of blood. Is that the right approach, or should we actually evaluate these patients? Now, let me start by saying that when we say that this is the normal range for hemoglobin, suppose we say that normal range for hemoglobin in men is say 12 to 15, in women it is 11 to 14. Normal range means what? If your lab says normal range for creatinine is 0.7 to 1.2, suppose. Then what is the meaning of normal range? How is this normal range derived? It is important for us to understand that for understanding a normal range, and I had spoken about this in one of our first lectures. What is done is you check the hemoglobin, WBC, platelet, creatinine, potassium, sodium, height, weight, whatever parameter you want. You check it in say 100, 200, 500,000 people. Now these people, they have to be normal, which means you take a history, they don't have any fever, cough, cold, they don't have any other illnesses. They are apparently normal, healthy people as far as we can make out clinically. Then you standardize the test condition. So for example, you say that, you know what, I'm going to take everybody's blood sample after they have been lying in a bed or sitting in a chair for 15 minutes, because our blood parameters can change depending on whether we have been running or walking or sitting or standing. There can be minor changes in our blood values. There can be minor changes in our blood pressure. So even when you have to determine what is normal blood pressure, you have to get apparently normal healthy volunteers and make them lie down in a test condition, all of them, and then you measure the blood pressure or the height or the weight, or you take a blood sample. Now when you take a blood sample for say 100, 200, 500,000 people, you will get a range. Somebody will have a hemoglobin of 12.1, somebody will have a hemoglobin of 18, somebody will have 8, right? So people will have different hemoglobin, WBC, neutrophil percentage, platelet count, and your creatinine, bilirubin, all that. All of these patients, well, they're not even patients, they're normal, healthy volunteers. You have to take their sample and you have to draw, when you actually plot it against an x-axis and y-axis, you will get a Bell's curve. And then by statistical methods, we figure out what is the median plus minus 2 standard deviation. So median plus minus 2 standard deviation will tell you what is normal. That means that will tell you what is the range for 95% of people. Just a minute. Yeah. So that will tell us what is the range for 95% of the population. 95%. The top 2.5% will have more than your range. Bottom 2.5% will have less than your range. So when we have a report which tells you that, look, normal range for hemoglobin is 12 to 15 or 11 to 14. Anything more than that is abnormal. Anything more than that is abnormal. So if somebody comes to you with a hemoglobin of 15.5 or 16, where are we getting this noise from? Okay, sorry. Yeah. So whenever you get any high value, okay, uh, it may be just hemoglobin more than, 15. So 15.5 is not normal. Don't ignore it. Don't just say, no, 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 15.5, great comeback. No, hemoglobin up to 15 is normal. If it's more than that, we need to evaluate. We need to evaluate. And why is this important? Because we know that as the hemoglobin increases, from 15 it becomes 15.5, 16, 16.5, 17, 18. There is a risk of high hemoglobin. There is a risk of high WBC and high platelet count. So your normal platelet count is up to 1.5 to 4.5 lakh. That's 150,000 to 450,000 per cubic millimeter. When the platelet goes above 450,000, that's more than 4.5 lakh. That's not normal. You need to find out why that is happening. Sure, I'm not saying that everybody you have to do a bone marrow test and this and that. No. But don't assume, yeah, this is minor, you can let go. No. And I'll tell you why. Okay. So now with this basis, I want you to understand that the reason we need to evaluate anybody whose hemoglobin is high, platelet is high, WBC is high, because they might be what we call as myeloproliferative neoplasm. Remember, this bunch of diseases, that is polycythemia, thrombocythemia, etc., they were called myeloproliferative disorder. Myeloproliferative disorder until about 10 years ago, 8, 10 years ago. But then it was understood that these are actually low grade cancers. And many doctors did not understand this. Many hematologists didn't understand it. And we would not evaluate them. And a lot of them, up to 25% of patients with high hemoglobin and high platelets, will have a vascular problem because the blood is too thick. It cannot flow properly if there is too much hemoglobin, right? Remember, the heart is a pump and the arteries and veins are pipes. So the blood has to flow through the pipes smoothly all around the body. For that to happen, the hemoglobin has to be just right. If it is too high, blood becomes thick, blood is too viscous, and hence it will not provide blood, and it can lead to vascular problems such as heart attacks, stroke, venous thrombosis. Up to 25 to 30% of patients with polycythemia and essential thrombocytosis will get this. Hence, do not ignore and do not forget, they are actually called neoplasms. They are cancers. They are low grade cancers. They are myeloproliferative. Myelo means marrow. The marrow is multiplying unnecessarily, and it is unnecessarily making too much hemoglobin, WBC platelets. Okay. So now with this introduction, let us figure out what are these myeloproliferative neoplasms, and does everybody with high hemoglobin have polycythemia vera? No, no, not really. So how do we evaluate? Does everybody with high platelet have essential thrombocythemia, which is a low grade neoplasm? No, 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 not at all. We will now go ahead and figure out how to evaluate. So when we talk about myeloproliferative neoplasm, that means a cancer of the bone marrow, where the bone marrow is unnecessarily multiplying and unnecessarily making too many cells. We have to first talk of CML. CML is a phenomenal disease because this is a disease which is a cancer. It's a type of blood cancer, but this is the first cancer in humans. Okay, amongst all the cancers, breast, colon, etc., CML is the first cancer where it was found out that, hey, there is a problem in the genomics of the cancer cell. And this was first published several years ago as a small letter to the editor, because they noticed There was a wonderful group, and they found out that in CML, patients, one chromosome is smaller than normal. One chromosome is smaller than normal. So this is the first cancer where a defined cytogenetic problem in the chromosomes was found in all the patients. Until then, we didn't really know. I mean, there was no proof that cancer was caused by a genomic problem in the cancer cell, not in the whole body's genome, in the cancer cell genome. So this is the first cancer where this was discovered. This is also the first cancer where targeted therapy was discovered. Okay, so as more and more research was done, it was found that in CML, chromosome 22 and chromosome 9, okay, chromosome 9 and chromosome 22, there they break. Part of the Q arm of this goes there and that goes here. So it's a reciprocal translocation, okay. Part of chromosome 9 breaks, goes to chromosome 22, and chromosome 22 part breaks and goes to chromosome 9. Okay. Now, because of this, what happens is on chromosome 22, there is a oncogene, an oncogene that is ABL1. That oncogene gets activated because of this. So this ABL comes from here and sticks here, it gets activated. What happens when that oncogene is activated? This translocation will make a abnormal RNA. The abnormal RNA will make an abnormal protein, and that abnormal protein, BCR-ABL fusion protein, will go into, and it will activate the nucleus so that it multiplies. Very simple. So there is reciprocal translocation, and which leads to an abnormal fusion protein, right? 9 and 22 fusion protein, which will activate so that the nucleus just unnecessarily multiplies in the marrow cells, hence myeloproliferative neoplasm. This leads to a cancer called chronic myeloid leukemia. What was also figured out that, all right, we know that there is this one genetic problem which is causing cancer. What if we make an inhibitor? So an inhibitor was made for this enzyme which is activated, tyrosine kinase inhibitor. It was called imatinib. This was the first medicine which was like a magic bullet. Magic bullet. So this will go and only attack this abnormal protein. It will not attack normal cells, right? So you know the genomics, now you have figured out targeted therapy. Now that's the beauty of CML. So whenever we have high hemoglobin, WBC platelets, whenever the bone marrow is multiplying unnecessarily, we have to first test for BCR-ABL mutation, BCR-ABL reciprocal translocation. Because if that high HbWBC platelet is because of CML, there is a targeted therapy. It can control the disease in 80% of patients. Imagine, take one tablet, your cancer is controlled. Beautiful. So this happened for the first time in CML. We should first test for this, right? Because this can give rise to high RBC, WBC platelet, and you treat it with one single tablet. Now, when we see any patient with high hemoglobin WBC platelet, we have done this mutation, and this comes as negative. When that comes as negative, okay, we put them into another category. We put them into another category, okay? We will first test for this BCR-ABL mutation. And this, was first discovered in the city of Philadelphia in the US. So it's called as the Philadelphia chromosome, Philadelphia mutation. So first thing we test this, if it is positive, CML treat. If it is negative, then we put the patients into a different group, a second group, which are called Philadelphia mutation negative. So even though
Help
this
பண்ண சொல்லுங்க. இங்கிலீஷ் வர சொல்லுங்க. இவன் அர்ஜென்ட்டா.
So even though this mutation is not there, the marrow is still unnecessarily multiplying, which means there are multiple genes in the nucleus of a cell. There are multiple genes that can trigger cell division, that can trigger mitosis, right? It's not just BCR-ABL mutation. There are various other genes and pathways. Now that is a separate bunch of patients. They are called Philadelphia mutation negative myeloproliferative neoplasm. And this is the group that we are going to focus on today. These patients also present with high RBC, WBC platelet, right? High hemoglobin, WBC platelet. They're negative for Philadelphia chromosome and they are a low grade malignancy. However, there can also be other causes of high RBC, WBC platelet, and we will come to that. And in this group, we have five major diseases. In those in whom hemoglobin is mainly high, we call them PV, polycythemia vera. In those in whom platelets are mostly high, we call them ET, essential thrombocythemia. And in those in whom overall WBC and marrow is proliferating, that is called, and eventually leading to fibrosis, those patients are called PMF, primary myelofibrosis. There are two other rarer diseases, chronic neutrophilic leukemia, chronic eosinophilic leukemia. We are not going to talk about these. These are very rare. We are not going to talk. And maybe eosinophilic leukemia, you might have heard in the talk about approach to eosinophilia. So our focus is on these three pH negative, Philadelphia negative, myeloproliferative neoplasm. Now remember, polycythemia vera is when you have ruled out causes of secondary polycythemia. Secondary polycythemia. That means there is something that is increasing erythropoietin. There is something that is causing high erythropoietin. That high erythropoietin is a kind of a trigger. It will go and trigger the marrow to multiply and make hemoglobin. That is secondary polycythemia or erythrocytosis. We see that in patients who are not getting enough oxygen. So in patients who have chronic hypoxia because of COPD, in patients who have congenital heart disease, congenital cyanotic heart disease, in patients who have a liver tumor which is unnecessarily making erythropoietin. So there is something outside the marrow which is making erythropoietin, and that erythropoietin goes in the marrow and it is making it proliferated. Primarily, the marrow is not affected. That's secondary polycythemia. We have to rule that out in all patients with high HB. Similarly, there may be something secondary which is increasing the platelet count. We have to rule that out. Two common conditions, iron deficiency and infection inflammation. Iron deficiency and infection inflammation. So remember, our platelets are an acute phase reactant. What that means is just like there is any infection or inflammation, your ESR will go up. Ferritin will falsely rise, right? Because ESR and ferritin are acute phase reactant. Any infection, inflammation, they will rise. Similarly, with any infection or inflammation, platelet counts will rise for a few days and come down. They will be reactive thrombocytosis, which will settle in 6 weeks, 1.5 months after the infection, inflammation, and iron deficiency is treated. So before we label a patient as ET, essential, that means there is nothing reactive. Primarily, there is a marrow problem, which is increasing platelet. Similarly, myelofibrosis, fibrosis of the marrow, marrow gets replaced by fibers. It gets damaged, right? Like in cirrhosis, the liver is replaced by fibers. Similarly, in myelofibrosis, the marrow is replaced by fibers. This can be secondary. Secondary can happen because of TB, right? Or some other such chronic problems. But when that is ruled out, you have primary myelofibrosis. That means there is nothing external, there is a problem in the marrow. So, whenever we see somebody with high HB, high WBC, high platelet, don't ignore. You rule out Philadelphia chromosome. When that is negative, you rule out other causes of reactive high HB, WBC platelet. When they are ruled out, your diagnosis is PV, ET, or PMF, which are called as pH negative, Philadelphia negative, MPN. Now, let us see how this actually happens. I told you that in Philadelphia chromosome, the BCR ABL genes stick to each other, and that ABL is then an oncogene. It will make the marrow multiply. But that mutation is negative in PV, PMF. So how does it actually, why does the marrow keep on multiplying unnecessarily? We need to understand that nature has done an amazing job in creating checks and balances. Nature has created an amazing job in creating checks and balances. What that means is I am staying in Bangalore, okay, and my body needs certain oxygen, and that requirement goes to the kidneys. The kidneys will secrete erythropoietin. Erythropoietin will go to the marrow. Erythropoietin will go to the marrow. You see this erythropoietin secreted by kidneys into the blood. Blood takes erythropoietin to the marrow. In the marrow, you see this cell is a precursor cell. Erythropoietin will go and get attached to erythropoietin receptor. There is a receptor, right? It's a lock and key mechanism. So erythropoietin is called the ligand. Anything that connects to the receptor and activates it is called a ligand. So in this case, erythropoietin is the ligand. It will go and attach to this erythropoietin receptor, which is actually on the cell surface, cell membrane. You see, this is the cell membrane, this is the cytoplasm, and this is the nucleus with the DNA, and this is the nuclear membrane. So cell membrane, cytoplasm, nuclear membrane. Inside that, we have the DNA. Erythropoietin comes and gets attached to the erythropoietin receptor. Erythropoietin receptor is the sensor. It will sense, all right, erythropoietin has come and gotten attached. That means I have to make more hemoglobin. So this receptor will give a signal. It will give a signal through multiple other proteins. Okay. It's like somebody tells me, hey, there is a new patient in OPD. Okay, or the new patient comes to the reception of the hospital. Receptionist will then call my manager will call me, I will go and see the patient, correct? So there is a chain of passing on the message, right? So the primary receptor is my receptionist. That's the receptor, and the receptionist will pass on the message to secondary messengers, which will be my manager, etc., etc. The message will come to me, and I will then go to the OPD and see the patient. Similarly, erythropoietin receptor, erythropoietin will stick to it, and secondary messengers are a group of proteins called JAK2. JAK2 is one protein. Then there is STAT, STAT5. So there are a bunch of secondary messengers. And these proteins then give a signal to the nucleus saying, okay, start making hemoglobin. Okay. And then this cell will, an erythroid precursor will then mature to form an RBC. All right. That is how in the bone marrow, erythroid precursors become RBC. Now imagine this receptor is a thrombopoietin receptor. Thrombopoietin is the signal for platelets. Okay. So thrombopoietin will come and stick to the thrombopoietin receptor, and this will get activated. Same, it will again activate the JAK-STAT pathway, JAK2 protein, and that JAK2 JAK-STAT pathway will send a signal into the nucleus of the megakaryocyte. The megakaryocyte is the precursor. Then it will say, okay, I need more platelets, so it will start manufacturing more platelets. Same thing happens to WBC. There is a GCSF, or there are several other, ligands. They will stick to the receptor, and then more WBCs will be made. So now we know how this happens, right? So something sticks to the receptor that sends a second signal that will tell the nucleus, all right, turn into this cell. How does the body control this? Now, once we have enough hemoglobin, the kidneys will shut down the production of erythropoietin. Erythropoietin production will come down. Blood erythropoietin level will come down. There will be less erythropoietin in the marrow, and hence less JAK2 signaling, and hence less hemoglobin will be made. Similarly, when there are too many platelets, the amount of thrombopoietin will come down. There will be less thrombopoietin sticking to the megakaryocyte receptor. Less signal, less platelets will be made. So there's this beautiful control, positive control and negative control to increase and decrease the number of RBCs, WBCs, platelet, the amount of hemoglobin that is made. However, however, sometimes what happens is you have crazy people. Sometimes there is a crazy person. Sometimes, my receptionist, even when there is no patient, she may say, no, 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 where is Dr. Sachin? He is not in the OPD, you call him. Okay. So there is no patient, but the receptionist is unnecessarily active and she's unnecessarily sending second messages. She is herself, her constitution, her personality is she's constitutively active. She doesn't even need a ligand. She doesn't even need the patient to come. Similarly, if there is a mutation in the receptor or a mutation in the JAK2 protein, it may unnecessarily keep on giving the signal even when there is no erythropoietin stimulating it. Even when there is no thrombopoietin stimulating it. It may unnecessarily give the signal, making the marrow proliferate, leading to high hemoglobin WBC platelet. So you see what happens is this is called myeloproliferative neoplasm. Why neoplasm? Why are we calling it cancer? Sure, it's low grade. Yeah, little bit of HB is high, little bit of platelets are high because they can progress to damage the marrow. In 10, 15, 20 years, if we don't manage polycythemia properly, if we don't manage ET properly, they can damage the marrow and lead to fibrosis, myelofibrosis. And that can eventually turn into proper leukemia, acute myeloid leukemia. So this low grade cancer over many, many years can turn into high grade leukemia, which can kill the patient. Okay. So that is the overview of the pathogenesis of these diseases, right? So in polycythemia, unregulated RBC production, you see there is no erythropoietin. There is a mutation in the erythropoietin receptor or mutation in JAK2, and some more proteins, which will unnecessarily signal the nucleus to make hemoglobin. And there are three genes that we know of today. Okay. Even if BCR-ABL is negative, we know that JAK2, MPL, and CALR, these are three genes. They are the commonest mutations which can unnecessarily give automatic signaling even if the body doesn't need it, even if erythropoietin, thrombopoietin, ligands are not there, and unnecessary marrow proliferation called myeloproliferation, and that's a low grade cancer. It can lead to high hemoglobin WBC platelets. Okay, so now let's look at these three: PV, mainly high hemoglobin; ET, essential thrombocythemia, mainly high platelets; and myelofibrosis. Now, what is this myelofibrosis? Why does the marrow get fibrosed? Why does the marrow get fibrosed? We've all studied in, second MBBS, most of us, when we were studying pathology and we were studying surgery and we were studying wound healing. So if I cut skin subcutaneous tissue, the wound will heal with fibrosis, right? The wound will heal with fibrosis. But in myelofibrosis, there is no damage, there is no injury. So why are fibers being laid down in the marrow? What actually is happening? Fascinating disease. And let me tell you, let me start by saying we don't really know how this happens. Okay, we don't know. Now, what happens in myelofibrosis is, those three genes, so JAK2, CALR, and MPL, right? These three genes that I told you, JAK2, MPL, CALR. These three genes get mutated, and how the mutation happens, it is not from childhood. As our age grows, as our life progresses, our cells are multiplying, marrow, hair, and as cells multiply, they pick up some mutation, they pick up some errors in the DNA because of mitosis, because of cell division. And by chance, if that error happens in JAK2, CALR, or MPL gene, you will get MPL. So as our age grows, these mutations may happen in our cells. And that is why these diseases are seen in 40s and 50s and 60s. We don't see these diseases usually in children because they're too young, their cells have not divided for so long. So in myelofibrosis, one of these three genes usually, and there are many more genes that we don't know of, right? We hardly understand biology. And one of these genes undergoes mutation, and that pushes the marrow into unnecessarily multiplying. HB in this, generally WBC also goes up in the initial phase, not just HB and platelet. WBC also goes up to 15,000, 20,000, 30,000. So initially there is marrow proliferation, myeloproliferation, and many times diagnosis is missed. People think maybe WBCs are high because of sepsis, infection, this, that. So we miss it. However, what happens after some time, after a few years, actually 3, 4 years, is this marrow starts getting damaged because of that excessive multiplication of division of cells, mitosis. We don't really understand. We believe that PF4 CXCR pathways is damaged, is affected, but we don't really understand the full pathogenesis of myelofibrosis. Nevertheless, initially marrow multiplies a lot, and then fibers are laid in it. And in the marrow, in the bone, if fibers are laid, there is no space for hematopoiesis. There is no space for making more hemoglobin WBC platelet, right? There's no space left in the marrow. So what happens is the marrow cells, the erythroids, they start entering the blood and they start going to different parts of the body. So the marrow precursors, the precursors which make RBC, WBC platelet, erythroid, WBC and platelet precursors, they start entering the blood and they start floating to different parts of the body. And that is called as extramedullary hematopoiesis. Extramedullary, that means blood production, hematopoiesis, blood production outside the marrow. Normally, the factor is the marrow. But when blood production happens outside the marrow, it's called extramedullary, medulla meaning marrow, hematopoiesis. First, it happens in the liver and spleen. So, as these precursors go in the blood, the liver and the spleen are filters. They will catch these precursors. They will catch these precursors. And there is no space in the marrow because of fibrosis. They have gotten out. Now they are trapped in the liver and spleen. In the liver and spleen, the marrow precursors will multiply. And the marrow, new marrow forms in the liver and spleen. Fascinating, right? And that's why the liver and spleen start enlarging. That is why in myelofibrosis we see hepatosplenomegaly. They're enlarging because liver, along with doing its job, is also making RBC, WBC platelets now. It is doing the job of the marrow, extramedullary hematopoiesis. This can also go in other parts of the body. So there can be a lump of extramedullary marrow, hematopoiesis around the spine, etc. It can deposit in different parts of the body, but that's rare. Usually, the liver and spleen take up the job of the marrow, and eventually the marrow completely fails. That is when RBC, WBC, and platelets actually start going down, which means even the liver and spleen is not able to compensate the production and it actually goes down. This is the fibrotic stage. So, myelofibrosis, initially we have proliferative stage, and then as fibers set in, we get a proper fibrotic stage, and later on, some patients will transform to full aggressive blood cancer called AML, acute myeloid leukemia. So these are how the three main types of Philadelphia negative myeloproliferative neoplasm, Ph negative MPN, happen. How do these get picked up? They get picked up by doctors like yourself, right? A patient comes to you for health checkup. Now, annual health checkup is very common, which is great. Sometimes patient is going for a surgery, hence CBC is done and the hemoglobin or WBC or platelet is high. They have no sign symptoms. Or sometimes they go for donation. They are being good Samaritans. No, no, my friend's father needs blood. I will go to the blood bank and donate. And the blood bank says, no, no, your hemoglobin is high. You're not normal. You're not normal. We can't accept your blood. Please go to a doctor. Please get checked out. So these are the patients who come most often to us. Sometimes some patients may come because of the splenomegaly, because the spleen is enlarged. That may hurt them. They may have weight loss. They may have early satiety. That means they say, Doctor, I used to have 5 chapatis. Now, after two chapatis, I'm full. Early satiety, because the spleen is filling up the abdomen. There is no space for the stomach to expand with food. So there is early satiety, and they also start losing weight. We also get patients because, like I said, when the RBC, WBC platelets are too much, the blood becomes viscous. The blood does not flow freely in the arteries and veins. And because of that, many times we have patients who get mild symptoms like headache. Okay. Or, yeah, just a minute. So they get mild symptoms like headache, or there may not be proper blood flow in the fingertips, because these are the end arterioles and capillaries. So they may have reddish, bluish, painful fingertips called erythromelalgia. Sometimes they get mistaken for Raynaud's syndrome, which is seen in connective tissue disorder. Sometimes they get pruritus, skin itching, especially after a shower. It's called aquagenic pruritus. Pruritus made worse by water. Sometimes blood flow to the eyes is not proper. So they will just see, doctor, I was fine, I was just sitting, and suddenly my vision become blurred. It's as if a curtain went on my eyes, and then immediately I was fine. So that curtain like transient visual disturbance is called amaurosis fugax. So because of sluggish blood flow, there may be mild symptoms or there may be major symptoms. There may be major problems such as a thrombus may form because the blood is not flowing properly. If the thrombus forms in the arterial system, can lead to heart attack, can lead to stroke, sometimes just TIA. We get young patients 30, 35 with hemoglobin of 18 presenting with TIA, presenting with a stroke, young stroke. This is the cause of that. Sometimes they may present with gangrene, but that's rare, gangrene of the limbs. Venous thrombosis can lead to deep vein thrombosis in the lower limb. It can lead to pulmonary embolism, and very, very commonly, it can lead to portal vein thrombosis. So the portal vein might get thrombosed. Very specific. Because what happens is not only is there sluggish flow, the liver and spleen are enlarged in myeloproliferative neoplasm. So there is a lot of blood flowing between the liver and spleen. And this excess blood flow plus high hemoglobin, WBC platelet can lead to thrombus in portal veins. So many times we actually get patients referred by our gastroenterology friends. They say, portal vein thrombosis, liver is fine, there is no cirrhosis. We don't know why there was thrombosis. And when we check, just the hemoglobin is high. Sometimes we get patients with thrombosis in the cortical venous sinuses. So they come to our neurology or neurosurgery friends, right? Now, in these patients, when there is a major thrombotic episode, we cannot ignore. We have to remove the excess blood immediately. So we start phlebotomy. If the hemoglobin is more than 15, we remove 1 unit blood. After 2 days, we remove one more unit blood. Then the family gets worried, doctor, you're removing so much blood. So, no, there's too much blood. But then what if he becomes giddy? Don't worry. We'll remove 1 unit and we'll give 1 unit normal saline. So that dilutes the blood and the hemoglobin comes down. So whenever there is an acute thrombotic episode with high HB, we need to aggressively control that hemoglobin. We can't really wait too much. But you will say, but doctor, is this really PV? Can the hemoglobin be high because of something else? Sure. Now let me tell you how we actually differentiate reactive from MPN. MPN meaning problem in the marrow. So I just told you the symptoms, it's written here. High HB, can be because of smoking. You all know that. In smoking, when the cigarette smoke goes in, it has a lot of carbon monoxide in it. And that carbon monoxide binds to hemoglobin, good hemoglobin, and makes carboxyhemoglobin. That carboxyhemoglobin is bad hemoglobin. It cannot carry oxygen, right? So part of the good hemoglobin becomes carboxyhemoglobin. So the marrow has to make more hemoglobin that needs to polycythemia. So there is something external that is stimulating the marrow. Same thing happens in cyanotic congenital heart disease. You don't have enough oxygenation, the kidneys will push out erythropoietin. Serum erythropoietin will go up. That erythropoietin will go in the marrow and push it to proliferate. Platelets, like I said, they can be reactive high in infections, iron deficiency, high WBC in sepsis infections. So whenever we get a patient of high HbWC platelet, you have to take this history. Do you smoke? Has an echo been done? ECG being done? What is the ferritin iron deficiency? Is there any fever, cough, cold? Are there infections? Those are the symptoms. On blood test, whenever somebody comes with high hemoglobin, especially in our country, which is a hot country, right? So we sweat a lot, they may be dehydrated, and dehydration could have led to Hemoconcentration, that means false high hemoglobin. So we tell the patient, all right, your hemoglobin is 16. Sure, drink 2 3 liters of water today, come back tomorrow. In a stable patient, okay, not somebody with a thrombosis and all that. In a stable patient, we say, yeah, no problem. You drink 2 3 liters of water, come tomorrow, repeat hemoglobin. Many times after hydration, the repeat hemoglobin will come down from 16 to 14. Don't evaluate further. That's it. Done. Nothing more is required. Yeah. This is for high hemoglobin. Okay. But dehydration can never lead to HB of 21. So when you have very high hemoglobin, don't assume this can be dehydration and hemoconcentration. Of course, you hydrate and you repeat the HB. That is fine. What you tell the patient, no, man, your hemoglobin is too high. We will need to evaluate. Yeah. How do we evaluate? We rule out secondary polycythemia by testing serum erythropoietin. Simple. If there is COPD, cyanotic congenital heart disease, or if there is a liver tumor which is secreting, unnecessarily secreting unusual site of secretion of erythropoietin, the serum erythropoietin will go up. So we do a blood test, serum erythropoietin. If the serum erythropoietin is high, higher than normal, then it is secondary polycythemia. It is not a cancer. It's not polycythemia vera. Of course, we'll do ultrasound abdomen for hepatosplenomegaly. We also want to look for liver tumors. We do chest X-ray. We do 2D echo and ECG to ensure that there's no cyanotic congenital heart disease, right? So this is the initial evaluation for high hemoglobin. What about high platelets? Platelets can be high because of iron deficiency, infection, inflammation. So if I have a patient with 6 lakh, 600,000 platelet count, with anemia, with ferritin being low, I will first give iron therapy. I'll first give iron therapy. If I have a patient with fever, sepsis, who is admitted in ICU, before admission, platelet was normal. After admission, as sepsis has gone up, platelets have gone up because they are acute phase reactants. I say, no, 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 no. This is reactive thrombocytosis. I don't want to do marrow exam. I don't want to look for mutations because 1 week ago platelets were normal. Now the poor guy has come with an appendix, burst appendix, road traffic accident, pneumonia, whatever. And with that infection and sepsis, platelets have gone up while he or she was admitted. This is reactive thrombocytosis. Treat the underlying cause, ignore, even if the platelets are 8 10 lakhs, nothing will happen. Those are normal platelet. That's part of normal immunity. Remember, platelets are part of normal immunity. That's why they increase in infection and inflammation. Once that infection, inflammation, iron deficiency is treated, 6 weeks later, the platelets will come down. And if they don't come down in 6 weeks, then you evaluate for ET, not otherwise. Okay. What evaluation? Yeah, look for hepatosplenomegaly and you do marrow. What about high WBC? You have a clinical scenario, like I said, sepsis, infection, pneumonia, UTI, high WBC, forget it, ignore it. Don't evaluate for MPN. But if nice, stable, walking, talking patient, okay, doesn't have even minor fever, cough, cold, no urinary symptoms, comes with a WBC count of 40,000, that can't be reactive. There's no fever, no inflammation. Okay, do CRP, do culture if you really want. But generally, this is going to be an MPN. Okay, it's very easy to figure out if somebody is so infected and septic that the WBCs are high. And if they look stable, don't leave it. Evaluate. Might be MPN, might be CML, might be pH negative MPN. So how do we evaluate further? Well, I'm going to come to, no, wait. I missed one slide. Sorry, just a minute. Yeah, confirmatory diagnosis. So confirmatory diagnosis is bone marrow examination. For high hemoglobin, high platelet, high WBC, when you ruled out dehydration, you ruled out infection and deficiency, etc., you have to do a bone marrow aspirate and biopsy, both. Not only that, in that bone marrow sample, you have to look for these mutations. So there is a test called MPN reflex panel. So when you send the blood to the genomic lab, they'll check BCR-ABL1. When that is negative, they will check JAK2, MPL, and CALR gene also. And if any one of these is positive, It is MPN and nothing else. So that person may be a smoker. That person may be a smoker, but if JAK2 is positive, this is polycythemia vera. You can't call it secondary polycythemia. Okay, that person may be having an infection, but if JAK2 MPL CALR is positive, it is an MPN because these genes will cause myeloproliferation. So there are various factors in the marrow aspirate and biopsy that our pathology colleagues look at and tell us, hey, look, there is something wrong. This is not reactive. And we also do the mutation, and thus we confirm the diagnosis of PV, ET, or PMF. How do we treat? Well, first you reduce the hemoglobin. Now, mind you, this is a treatment for MPN. We don't do venesection for secondary polycythemia. Okay? In cyanotic congenital heart disease, in COPD, the high hemoglobin is the body trying to help the patient by making more hemoglobin. Okay, so in PV, we will do venesection. We will remove, 350 ml of blood. We'll tell them go to a blood bank, phlebotomy, remove 350 ml blood and throw it away. It can't be used for another patient because this is a cancer. You cannot give blood from an MPN patient to a normal person. Okay, so you remove and you discard that blood once in 1 week, once in 2 weeks. Then as we keep on removing blood every 1 or 2 weeks, the hemoglobin stays below 15. And then we say, okay, now we don't need to remove every 2 weeks. You remove once a month, once in 3 months, once in 6 months. After 1 to 2 years, even without venesection, the hemoglobin will stay below 50 because now we have removed so much blood that the patient has become iron deficient. Iron deficient. So we do phlebotomy initially very frequently to make the person iron deficient. So no raw material, no iron. Even with the genetic mutation, HB cannot go up. Even with myeloproliferation, hemoglobin can't go up. So we do venesection. However, this is for PV. For secondary polycythemia, the targets are different. And we don't manage this. We send them to cardiologist. Cyanotic congenital heart disease, boss, you manage. This is not a marrow problem. Similarly, for essential thrombocythemia, we don't have to reduce the platelet unless they are more than 1 million or more than 10 lakh per cubic millimeter. Nothing will happen. Myelofibrosis high WBC count has to be controlled. So we control it with a tablet called hydroxyurea. Hydroxyurea will reduce the marrow production. Okay. So hydroxyurea controls WBC count, will improve the weight because marrow is proliferating so much, it is consuming the calories, leading to weight loss. So when you give hydroxyurea, the weight also improves. Yeah, that's the supportive, that's controlling HbWBC platelet. We have to then prevent the thrombosis. So all three conditions, PV, ET, PMF, we start aspirin, low dose aspirin, 75 milligram lifelong. All three. Okay. Hydroxyurea is given to PV-ET patients if they are at a high risk of thrombosis. What do you mean by high risk of thrombosis? Those who are more than 45 years of age. Those who have other problems that can lead to AMI, so diabetes, hypertension, and those whose WBCs are also high because that really creates a pro-inflammatory state, right? So in these three conditions in PV, remember, not secondary erythrocytosis, not secondary polycythemia vera, we add hydroxyurea only if these three things are there, one of these three, or else we just give aspirin and phlebotomy for all the patients. Same thing for ET. If platelet goes above 1 million or more than 10 lakhs, then you have to use hydroxyurea. Otherwise, there can be increased risk of thrombosis, AMI, DVT. Interestingly, as the platelets increase beyond 10 lakh, instead of clotting, patients can present with bleeding. They can present with bleeding because coagulation is very funny. What happens is as the number of platelets in the blood increase, the coagulation factors, they are proteins floating in the blood, right? Coagulation factor 1, 2, 3, 4, you all know that 13 factors. So these coagulation factors can get attached to the platelet cell membrane, absorbed. And that is why there may be artificial coagulation factor deficiency, counterintuitively leading to bleeding when the platelet goes up. So when the platelet is more than 10 lakhs, more than 1 million per cubic millimeter, we don't start aspirin. We first start hydroxyurea, reduce the platelet, and then add aspirin. Okay. So supportive care, thrombosis, prevention of thrombosis, And of course, you have to tell them, look, sure, you may have PV, but if you continue to smoke, the hemoglobin is going to get worse because somebody can have both the problems, right? They may be smoking and leading to lung damage along with PV. You have to stop smoking, stop alcohol. In myelofibrosis, later stages when they get anemia, there are some regimens with medicines like danazol, thalidomide, which can help increase the hemoglobin for some time. Sometimes myelofibrosis patients, the spleen increases so much, there is pain because of splenomegaly. There can be splenic infarct because the spleen is so large, blood supply cannot happen. That pain, we have to give pain relief. That's the supportive care. And finally, the definitive treatment is bone marrow transplant. You have to replace the marrow. But most of the polycythemia patients don't need it. 99% or so, well, 96% don't need bone marrow transplant. You just do phlebotomy, you give aspirin, enough. Still, if hemoglobin is not controlled, there is one medicine called ruxolitinib. This ruxolitinib is also a targeted treatment, okay? It is JAK2 inhibitor. I told you that JAK2 protein, that gene, this is a JAK2 inhibitor. So you can use ruxolitinib in some polycythemia patients. ET patients generally, they're managed by hydroxyurea very well. Platelets come down, aspirin, hydroxyurea enough. Myelofibrosis, however, is a bad disease. Most of the patients, you have to give targeted therapy. You have to use ruxolitinib. It's a tablet. It works beautifully in patients, right? Majority of the patients, the spleen will shrink, the WBC, HB platelet will come down, they will gain weight, their really quality of life improves. So this targeted treatment, ruxolitinib, JAK2 inhibitor, can really help myelofibrosis patients. Here you have to give proper treatment, majority. And when it progresses a lot, you have to change the marrow. There's nothing else that can be done. Okay. So this is how we treat. So now, summarizing for all of you, what happens is the marrow unnecessarily proliferates because the receptor may be mutated, or the JAK2 gene or CALR MPR gene may be mutated. They're unnecessarily signaling the nucleus to multiply even when there is no stimulation from erythropoietin or thrombopoietin. Okay. Constitutive, unnecessarily it is signaling, right? These are the mutations. We have to rule out BCR-ABL mutation because CML is a proper cancer, needs to be treated. When that is negative, BCR-ABL, we call it PH negative, Philadelphia chromosome negative myeloproliferative neoplasm. We have to look for other mutations, do a bone marrow, and try to control this. Don't ignore, don't ask the patient to donate blood. It's not safe blood, right? You have to diagnose them, follow them, because some of them, even polycythemia can progress to fibrosis. ET can progress to myelofibrosis, right? So you have to follow them for the next 15-20 years. Some of them can convert to a proper leukemia. Yeah, this is how it happens. So some patients may be born with some genetic mutation that predisposes them to MPN. It predisposes them. In addition, any one of these genes gets mutated, the marrow starts proliferating, starts making unnecessary HB, WBC platelet. Then for 10 to 15 years, that's all that happens until as the marrow multiplies, the cells pick up more mutations in more genes which are given here. That can then push it into complete fibrosis and sometimes AML. So this is how additional mutations over the years can make the patient worse. Thank you so much. I'll be happy to take questions.
So there are some questions.
Okay.
Are there any drugs or foods which can cause just
Yeah, good question. So,
increase
yeah,
in
yeah,
erythropoietin?
yeah.
They
So
can mimic erythropoietins. Yeah.
yeah. So danazol is danazol, stanozolol. These are androgenic steroids. Androgenic steroids means they will go in the marrow and push the marrow. So danazol, stanozolol, these can cause a false increase in hemoglobin. First, then there are GCSF, growth factor injections, which are given to cancer patients. When we give chemotherapy, leads to bone marrow suppression, WBC goes down. So we give GCSF injection to bring up the WBC neutrophil so that we can prevent infection. In them, WBCs can go up to 20, 30, 40,000 because of GCSF injection. But in them, we know clearly this is a person on chemo, WBCs were down, we have given injection. That's why they have gone up. Those patients we don't evaluate for MPN. Okay. Then which other parameters to see in CBC for hemo concentration? Nothing. The only way you can say whether blood is concentrated or not is by diluting it. So you ask the person to drink 2-3 liters water and repeat hemoglobin. That's the only way you can make out whether it was a false high HB or not. A patient with secondary polycythemia whose blood has removed, that blood can be used for donation. Uh, Technically, yes. But one core concept of blood banking is you don't want to cause any harm to the patient who's receiving blood. Okay. Primum non nocere. Primum non nocere is the Latin word, means first of all, don't do any harm. So when there is any doubt, the blood bank, a good blood bank should reject, saying, look, whatever it is, you are not normal. Okay. And hence, we don't know what is happening. We don't want to take your blood and maybe even by mistake cause a problem to somebody else. So primum non nocere is a very important tenet of blood banking. So we should avoid. Any indication of antiplatelets? Yeah, aspirin. So if hemoglobin is high, WBC platelets are high, until you figure out whether it is primary or secondary, please start low dose aspirin. It's safe. Very rarely will it lead to GI bleeding. Can we use clopidogrel instead of aspirin? Yeah, of course. But why? I mean, aspirin is cheap. It has been evaluated, but both are equally good. So PCV in CBC, significance in clinical practice. Now, if you actually read hematology texts, it will say that in polycythemia vera, you do phlebotomy until the hematocrit, the PCV comes below 45. Okay. Excuse me. And that is what I should be teaching you. I should be teaching you that the target is not hemoglobin of 15, target is hematocrit of 45. But what happens in most of the labs in the community, the hematocrit value may not be accurate. It's more confusing for patient and the community doctor. So I use hemoglobin as a surrogate marker, but you can use hematocrit. Sorry, I have allergic cough due to the AC. Thrombocytosis will normal HB, low iron, yes. Do a ferritin. If ferritin is low, give iron. 6 weeks later, if the platelets are still high, then you evaluate for ET. Any other question? Just close the AC. Yes. Sorry, go ahead.
There's a question.
Okay.
Hematocrit high, normal HB versus hematocrit high, high HB.
It should not happen. The rule of thumb is hemoglobin into 3 is hematocrit. So if hemoglobin is 10, hematocrit should be 30. Okay. And just hydrate and repeat from a better lab, better machine. That's all. It should not happen. Both go together. Hemoglobin and hematocrit increase and decrease together if you're testing in a good machine, in a good lab. Anything else?
I think the baseline, sir, as you would also agree, is we always have to do our test in a standard lab which has good accreditation standards. And also, you need to get connected to your hematologist, pathologist, and microbiologist, closing the loop.